All right, it is 7:01 and we want to honor everyone in their time. And first, thank you all for joining what is which will be a dynamic conversation. Tonight, we're going to be discussing a topic that, while it is in some discussion spaces, sadly, oftentimes does not include the voices of the women who are most severely impacted. And that's really lifting up, highlighting, and honoring BIPOC women in the conversation about maternal health. Sadly, as is the case with many health issues, women of color, Black, Indigenous, Latinx, we suffer disproportionately rates of infant mortality, of maternal health issues, even dying in childbirth, which when you think about the fact that we are in the United States of America seems almost unreal. But sadly, it is a reality. So we've established an amazing panel to speak with you, answer some questions you may have, talk about things that you weren't even thinking of. And what's really key is having this conversation before you're even pregnant, right? So sometimes we think maternal health, oh, I don't need to worry about that. When I'm expecting, then I'll worry. Or even our potential partners, they don't think about their own health or ours, but really planning for a baby happens before you're pregnant with the baby. And if you already knew that, just, you can say it in the chat, give me a little wave, but it really begins, maternal health begins before the point of conception. So starting off, I'm going to introduce our panelists. And if I can just ask Sora Hayes, if you wouldn't mind just bringing up the slide deck.
Sure.
Thank you. And if you see me looking off to the side, I am not watching something on TV. I'm sitting here working with two computers right now. So first and foremost, just to kind of backtrack a little bit, I have to announce that this is a collaborative effort among 3 alumni chapters of Sigma Gamma Rho Sorority Incorporated. Alpha Nu Sigma, which is covering Wilmington, Delaware. Iota Alpha Sigma in Northern New Jersey. And Theta Rho Sigma, which is my home chapter in the Bronx, New York. So couldn't have asked for more amazing partners in this, and so excited that we were able to collaborate and bring this to you. For those who don't know, I'm Sora Nicole Adams, also known as Knick Knack. My bio's like this, so it seems a little weird talking about myself in the third person. So I'm gonna skip me and just go right to our panelists. So we have, all right, and going in order, we have Dr. Tanya Ohly. She is the Director of Family Planning, Department of Obstetrics, Gynecology, and Women's Health at New York City Health and Hospitals, Kings County, and Brooklyn, New York. In addition to providing care for patients in the Women's Option Center, she is also the Residency Site Director for OB/GYN trainees from SUNY Downstate and started a Kenneth J. Ryan residency training program to enhance your education about family planning. Additionally, she is the medical director for the Title X Family Planning Grant. As a regular contributor to the Health and Hospitals Reproductive Health Working Group, she has also helped develop clinical guidelines on medication abortion and develop metrics for quality and safety of reproductive health across the health and hospital system in New York City. welcome Dr. Ohly.
I'm not too sure, but
next, I'd like to introduce Tia Diggs, who is a doula at Graceful Journey Doula Services. Sorority Diggs is a birth and postpartum doula, as well as a breastfeeding counselor. She's a wife and mother of 5.
yeah.
I had to make sure I read that correctly. I only have 2, and I barely survived. So I commend you and respect you, and currently resides in Charlotte, North Carolina.
Sure, I hate to interrupt you, but we can't hear. I'm not sure what's going on, but we can't hear.
Oh, if everyone could just make sure they're muted, please. That would be awesome. Thank you. And to give Sorority Diggs her true due respect, I will begin again. So Sorority Diggs is a doula at Graceful Journey Doula Services. Sorority Diggs is a birth and postpartum doula, as well as a breastfeeding counselor. She is a wife and mother of 5 and currently resides in Charlotte, North Carolina. She has used the doula for all 5 of her children's births, whether the birth took place in the hospital, birthing center, or at home. Tia is also a member of Sigma Gamma Rho Sorority Incorporated. In the 2 years that Tia has been a practicing independent doula, she has supported over 20 births, including, but not limited to, virtual births, home births, hospital births, C-section, and birthing center births. Tia's goal as a doula is to support whatever decisions you choose in order to birth your desires, help you find the power that already exists inside of you, and be a source of education for inquiries. A person's birth experience can have a lasting impact on their lives, and she strives to make sure clients feel supported and respected mentally, physically, and emotionally. Thank you and welcome, Sorority Diggs. Next.
Thank you.
The next slide, please. Next, I would like to welcome and introduce Rachel Ruel, who is co-director of Sister to Sister Community Doulas of Essex County, New Jersey, and SPAN Parent Advocacy Network. Rachel's career has been spent with relationship-based support for the perinatal period through policy coordination and direct client services. She is a co-director for Sister to Sister Community Doulas and at SPAN Parent Advocacy Network. In the last 5 years at Sister to Sister, Rachel has led an innovative community doula program in Newark, New Jersey that has been replicated in other areas around the state. From mentoring new doulas to ensuring resources for families, the Sister to Sister Community Doula program is changing the culture of birth in New Jersey. Prior to arriving at SPAN, Rachel was a WIC breastfeeding peer counselor for 3 years in New Jersey City beyond the local WIC office. Rachel provided home visits for WIC enrolled mothers who were part of a community doula project and at local Hudson County hospitals. Within New Jersey, Rachel participates on work groups, vision of high quality, respectful maternity care. Nationally, she is a member of NQF, Maternal Mortality and Morbidity Work Group. Rachel is a Bella leader in the Health Connect One Leadership Academy. She has an MSW in social work from Columbia University, and with a focus on reproductive health. She is a trained Lamaze childbirth educator and attended the Health Children's Project Certified Lactation Counselor Training. Rachel lives from an anti-racism lens and is committed to encouraging herself and her fellow white sisters and brothers to do better through vulnerability, accountability, and transparency. Rachel is originally from Massachusetts, but has lived in the New York, New Jersey metro area for 17 years. Rachel appreciates the elements of earth, cooking delicious soup, opportunities for healing, and spending time with her 2 sons, Molly and Marcus. Thank you and welcome. And last but certainly not least, I would like to introduce and welcome Michelle Gabriel-Caldwell, who is the owner of Baby Please Birth Services, located in New Jersey. Mrs. Gabriel-Caldwell is a certified doula and certified childbirth educator teaching the Bradley method, evidence-based method, and her own holistic course expressly for the Birth Center of New Jersey, where she is the doula coordinator. Michelle serves on the National Black Doula Association Advisory Board, where she revised the doula training curriculum to enhance the needs of Black doulas working in systemically racist environments. As an MBDA doula trainer and doula mentor, she spends her time providing critical thinking skills for her students to be successful and competent in their fields. She is also a poppy seed health advocate, supporting birthing persons virtually, where access otherwise would not exist financially. In addition, she established the New Jersey Virtual Doula Program for Overlook Hospital by galvanizing over 40 local doulas to volunteer their time during the COVID crisis. Michelle recently cross-trained with Doula International to build on her expertise as an educator. She is co-founder of the New Jersey Birth Justice Collective and committee chair of the Perinatal Health Equity Foundation, creating awareness to Black breastfeeding families and infant mortality. Michelle tirelessly works in the birth industry, and this has been since 2005. She has helped over 400 families navigate their birthing spaces, offering training for birth professionals while ensuring birth justice through state and national initiatives, serving on nonprofit boards and panels, enhancing the platform through blogs and podcasts. A mother of 2 wonderful children born by amazing natural birth experience. She's been married for 23 years to an incredible man who shares her birth passion. He teaches childbirth education classes with her to share the partner perspective. Michelle empowers others by offering education, support, and advocacy. She is also a full-time chemical engineer working for a German-based company. How do we find the time? She holds degrees in chemistry, mathematics, and chemical engineering from Xavier University and NJIT. Thank you all so much. Just the wealth and richness of your bios. I could almost stop there, but I won't. We have lots of questions that we're going to get to, and we're going to just dive right in. So birthing options, you know, all of you are advocates for, champions for birth experiences. And we heard a little bit through your bios about different birthing options. So first and foremost, how early should women start creating a birth plan? What is a birth plan? All right, I can pick on you.
Okay, I was wondering, are you going to call on us, or I was like, how is this going?
Nope, just as you feel moved by the spirit.
Okay.
Please.
Well, you're going to have a hard time because I'm moved by it all. So I would like to answer that question. So the first question is, when should a person be creating a birth plan? Literally when that stick says you're pregnant. Thinking about the idea of the care, the prenatal care in those moments, as well as your nutrition component, your exercise, who your birth provider will be, where you're going to give birth. All of those things are and should be part of the birth plan. What is it? It's not just a piece of paper. It really is a conversation between yourself, your husband, your spouse, your partner, your birth provider, and whomever else is going to be on your birth team. So it's really a wonderful communication tool to make sure that everybody's on the same page with what you want. And I would like people to feel that it's their voice written on paper. That's what a birth plan is. And when should you do it? As soon as you know you're pregnant.
Thank you so much for that, Michelle. Rachel, you looked as if you wanted to jump in there.
I didn't, but if you are calling on me, then I will come. I think also some options can be unfortunately predicted by the insurance that you have or the hospitals within your area. And that's the sad reality for some families, is that not all options are viable for every family. So I think that when and if we are working with families that do have some limitations, we need to tap into the options that are most important to that family, like freedom of movement versus a hospital itself. Even though some hospitals tend to dictate or want to dictate what you can do and can't do, I think building self-efficacy and supporting families very early on, that freedom of movement, and sometimes those most important things we want to tap into in a birth plan, because not all options are viable, unfortunately. That needs to change.
And thank you so much for sharing that point, because that, as you said, unfortunately is a reality. Tanya, if I can just tap you for a second, as a director of family planning, how do you speak with pregnant women and families about birth plans and work with them through that?
Thank you for inviting me to be part of the panel on this question. In my work in family planning, I've become very focused on helping women when they are in a situation where the pregnancy won't be continuing, either due to miscarriage or elective termination of pregnancy. And one part that we do always review with patients is what would be their plan moving forward regarding when they do want to become pregnant, when they do want to parent, or if they want to prevent that. Because in my mind, the most critical time to think about a birth plan is when you're thinking about, do I want to become pregnant in the first place? And trying to determine how much control you want to exercise over that reality, that possibility. I will say also, to answer the question a little more specifically, depending on insurance, depending on zip code, depending on geographic constraints rather, I think a lot of people feel that they don't have a lot of options in terms of where to birth. And that's really where two things become really important. I would say for someone who knows that they don't have a lot of medical problems, they should be certainly looking for facilities or institutions, if that's where they want to deliver, where the delivery process is nurse-led. What I mean by that is when they show up at the hospital, they may not see a doctor the entire time. The doctor might come in at the very last minute to just say hi to the baby or say hi to the mom. If it's a nurse-led institution, that means the person managing your labor, reviewing your birth plan, respecting your birth plan, is a little bit more in touch and a little bit less intervention focused. And the second item, it may be clear from the panel, but as the non-doula, I might just add that if you're trying to make a birth plan, I think the presence and support of a doula at the moment you figure out you're pregnant is actually critical. Just to share my personal story, when I was first pregnant, the first thing I did, I was a resident in OBGYN, and I found a doula who could work with me for my entire pregnancy. Now, unfortunately, my water broke while I was operating, so the doula didn't make it in time. But we are taught in medical school that the single most effective intervention at preventing cesarean sections is bringing a doula into the obstetric and prenatal care. So why on earth hospitals have not figured out how to work hand in hand with doulas in a more collegial and respectful fashion is just mind-boggling. So I think I've veered off a little bit, but that would be my response. I think people really need to embrace that, birthing plans are sort of a moment-to-moment thing in your life. If you're having sex and you're with a heterosexual couple and you're not using birth control, and it's possible you might become pregnant, I think it's time to make a birth plan. I really do.
Thank you so much for that. And Tia, not to put you on the spot, was there another perspective that you wanted to include in that question?
Yes, actually, just to piggyback on what the others have said, I agree, but I also have the have somebody else.
Everyone can please mute your phones and computers. Whoever Nicole is, we need her to mute. So, all right, I just muted her.
Okay. I definitely agree. I think when it comes to when you find out you're pregnant, creating a birth plan, what I like to call birth preferences with my parents, because I don't want them to think that as soon as they create a plan, it has to go tick for tick. It has to go item by item, because if something goes off, then it's like, oh, I failed, or my body failed, or we failed. So yes, you may hear birth plan, but I typically say birth preferences, because I want them to map out what's important to them and start to have those conversations with their provider as soon as they know what's important to them. So that way their provider starts to know ahead of time, okay, this is what, it starts to provide that individualized care from the beginning, as soon as they know what that parent wants, whether they want to try to go unmedicated or whether they just want it to be a low intervention pregnancy and birth, that their provider knows ahead of time, they've discussed it, they would keep it in mind and not trying to push their own personal agenda, but keep it as an individualized care and say, hey, I know that this is important to this person, so let me, maybe give some alternative suggestions when it comes to XYZ. So I like to say, birth preferences is still like a birth plan, but I also, encourage my parents to be flexible with it, because you never know how labor is going to go. Like, I mean, if someone could pick it, they'd probably win the lottery numerous times over. If they could tell how a person's labor is going to go from the beginning to the end, but we never know. So it's like, since you don't know, pick what's important to you, and then start to discuss that with your provider. But as soon as you know that you're pregnant, go ahead and start thinking about what's important to me. What do I want to keep at the forefront, and what do I want my provider to know regarding my care?
Yes.
Thank you, Tia. Can I just add one more thing to that?
Yeah.
That's absolutely important to make it fluid. It's not some, rigid thing that you have to follow tick by tick. It's also equally important to think about a postpartum plan or preferences, because that often gets left at the, the doorstep when you're walking your baby inside. And, what do I do next? I planned all of these things for this amazing birth experience, and now I have this baby and I don't have anybody to support me with whatever I'm looking for in terms of breastfeeding or just care and postpartum healing. So equally important, I would totally sit down and talk about postpartum plans, and then making sure that whatever it is that they've decided on the birth part or the postpartum part, that they're really looking at what their preferences are in order of priority. So because, flow and ebbs of things can change, conditions of the pregnancy can change. So maybe I don't get this fully unmedicated birth, but maybe I still get some other things that are really important to me. So really sort of thinking about it from that end. And I totally appreciate the fact that you used the word preferences, because that's really what it is. It's what am I looking for in this moment in time, and knowing that it can change over time, that it stays fluid.
Thank you. I'm sure we've all heard that expression, the best laid plans. So, you, or the other one, you plan and God laughs. So, so thank you for introducing that word preferences. And we're actually going to go back to the postpartum period a little further on in this conversation, but not to get too far from the birth preferences and the birthing experience. If we can just hear from two of you about the differences between a midwife and a doula. I'll share a quick personal story. I do have 2 children. who are old, and I call them my roommates now because that's how old they are. But I gave birth, it was at a freestanding birth center with a midwife. And I will say that even working with the midwife, I wasn't aware of a doula, you know, and what a doula was and what their role, function, responsibilities are. So if we can just have a couple of you quickly share out, what's the difference?
Sure, I'll go first. So with a doula and a midwife, one is clinically trained, they do medical things. So the midwife can check your blood pressure, does cervical exams, can, you know, authorize to have labs done, or, you know, issues for labs to be done. They look more at the medical side of things, whereas a doula is more of like a support person. I call it like your birth bestie, like they're knowledgeable, they're supportive, they're encouraging, they help you find the power that's already inside of you when it comes to your birth. And they're like more of like a space holder too. So it goes beyond just the physical, you know, hip squeezing and back rubs, but when you have a question, you just left your doctor, your midwife's office, and they ran all these acronyms to you like, oh yeah, the NST and the this and that and the third, and you don't know what any of it means. And you still have to process that in that 15-minute, you know, meeting. So you leave like confused. So it's like, let me call my doula because I don't know what they just said to me. And I had to leave because they had another appointment. So it's like helping, you know, having someone to process that with you and helping you to understand your options. Kind of going back to the birth preferences a little bit, where a doula can help you map out your birth preferences. And what I do is like, I go over scenario by scenario. So what would your birth preferences be? What would an induction preference look like for you? If any case happened, you had to have a cesarean, what would that look like for you? So that way, you know what your options are, what different pain medications there are if you want, and that we just go dive deep into options, but at the same time, also encourage them to be advocates for themselves. To be self-advocates too, if they feel like something's not right. So, or, you know, something doesn't sit with them well, we teach them, you know, hey, you can speak up for yourself. This is your body, this is your baby. So just helping them to find that power that already exists inside of them to use their voice, but also to help, you know, to support. We're part of the birth team. So we help support everybody there, not just the birthing person, but the partner too. Or if the mom is there, like we're there just to help make sure that the harmony is in the room, but also for that birthing person. Whereas, you know, a midwife, they're, you know, all things medical. So they're checking, you know, heart, fetal tones and, you know, like I said, blood pressure, drawing blood, stitches if they're needed, you know, administering medications if they're needed, but that's outside of the scope of what a doula does. So.
Thank you. And before we have another amazing answer, we do have questions. A question that was popped into the chat, and that is, what role does the OB play? And who has more authority? So, you know, if you have, it's almost a setup to a joke, right? An OB, a doula, and a midwife walk into a bar, but you know, but you know, walk into the delivery room. Who has the authority? Who has the, you know, what is the hierarchy?
If you don't mind, I can answer that a little bit. Honestly, the person who has the most authority is the birthing person. But the other part of that in the scale of the hierarchy in the hospital space would be the OB. The OB has more power, more authority over the midwife, over the doula. But you know, yes, body autonomy, that's all about the mom. So when it comes to the differences between the midwife and the doula, there are other things to also consider is the, and whether or not you want to choose an OB, because you don't have to have a midwife and an OB. You can just work with the midwife. The OB typically is the surgeon in the room, in the space. So if you're needing a cesarean, then that would be performed by the OB, not necessarily the midwife. The other thing I wanted to say is in terms of the doula's role is we're very much, as Tia alluded to, very much informational support. Everybody thinks that we are just high on comfort measures, and we are. You know, we've got our bag of tricks and everything like that too, but we're more specifically about making sure that you have all the information that you need to make an informed decision. Honestly, anyone who hires me to be their doula, I require them to take a childbirth education class with me. So we're spending all of that time making sure that during the labor, we are not having these quick questions about, well, what's an episiotomy and what's a whatever. They already know that going in. And so my focus at this point can be really just making them comfortable in their space and offering different position techniques and things like that. The other piece that I wanted to just sort of throw in there with the differences between an OB and a midwife, and this doesn't categorically go across the board, but there's something called the midwifery model of care and the medical model of care. And typically the midwifery model of care is about looking at everything that can go right? Everything that's normal, physiologic, natural, that kind of perspective. And then the medical model of care is kind of focused a little bit on the, okay, what do we know statistically can possibly go wrong? Mm-hmm. And it's not to say that an OB cannot follow the midwifery model of care, because I work with an amazing OB at the Birth Center of New Jersey who follows completely the midwifery model of care. So just wanted to throw those two concepts out there. And really, if you are starting to interview people and physicians, asking them whether or not they're subscribing to the midwifery model of care.
And Michelle, thank you for, I see you, Tanya. Michelle, thank you for that. Just going back, reflecting on my own experience, and really as we were planning for tonight, and thinking back, well, what happened those two times? I do recall when for my first child, working with the midwife, she said, listen, doctors will treat pregnancy like an illness, where your midwife is going to look at it as this is a natural occurrence. This is what we do. And, this is a part of nature, and we're just going to roll with it, versus having you, in a bed, hooked up to machines and monitors and so on and so forth, and being looked at as if you're being treated for an illness. So as you were speaking, that memory just came back to mind. But thank you so much, Tanya, for indulging me and letting me just slip that in there.
Of course. I think it's really, really important to understand the different roles that people can play in a pregnancy and at the time of a delivery. And I'll be the first person to admit that I think in some ways I'm suited for the job that I chose, because I think about the world as a series of risks. And so my outlook is to try to avoid risk, and I'm comfortable in that zone. I think the ideal birthing scenario is when a woman knows what it is that she wants in the birth experience, has articulated that with a birth partner or a doula who is completely aware and has gone through, like Tia just said, the scenarios, what could happen, what may happen, what her preferences are. And if she's having her delivery in an institution where there are people like midwives and obstetricians, that it's a team-based approach. So I've been in rooms with on labor and delivery with women that are delivering with a doula, and I'll talk to the woman who's in labor, and I'll talk with the doula. We'll talk all together. We'll make sure that everyone's goals and preferences are known. But building the trust with your doula, building the trust with your healthcare provider is probably the single most critical thing that's going to influence your experience of your birth. I'm not here to minimize real significant health disparities that exist in communities of color and what that means when you come as a pregnant person to an institution where they're going to further medicalize you. But I want to impart to the community tonight that if you meet a provider and your instinct is telling you they're not listening to me, it's because they're not listening to you. And if it's at all possible, trust yourself to say, I had this concern, I voiced it, I didn't get an answer. That's not okay. It's not okay to not get an answer to your question. If you're in a practice, you can ask to please be seen by somebody else. You may not have control if you're in a hospital who's going to do your delivery. But if there's someone in the room that you trust, that you know in your time of labor pain, and if you're in the zone, that someone can advocate for you and you're in a trusted practice, that's probably going to give you the single best outcome. And from your perspective, later on in time, looking back, you'll know that you worked with a trusted team. So I'm an advocate of the team approach. So when there's a midwife doing a delivery on labor and delivery, it's her delivery. I say, do you need me for anything? And when the baby comes out, it's under my license. In the end, I have to sign off on it. So there's a whole litigation and risk of lawsuits that doctors, tend to sort of get in the scene, maybe feels premature sometimes. But there is a concern about safety that sometimes with the risk perspectives tends to overshadow the process. But if you find a good team, you will be delivered by the person who you thought was going to deliver you. You will be supported by the person who you thought was going to support you. And you can feel that out. So I don't want to go on. I could go on and on, but I'm going to stop right there.
Well, thank you so much for that. And Rachel, I was coming to you because there was something that Tanya said, and this isn't one of the questions that we had discussed in preparation for tonight, but something, the anti-racist work that you do, you're very intentional about stepping into and supporting communities of color. And, we're hearing it's your voice, advocate for yourself. How do you see this play out with the women that you're working with? Yeah. And how do you try to help support them in that?
Okay. So my role at Sister to Sister is not providing direct care. I see myself more as a facilitator that is transparent with budgeting, with the structure, with the way that we run our meetings. That's my role at Sister to Sister. My role is not direct service, but we are intentional about the trainings that we have supported. Michelle is one of our professional development trainers. We're very intentional about the community-based doula trainings and about how we do things within Sister to Sister. A lot of doulas, and I've been a trained community doula my entire career, even though I'm not an active doula right now. But I'm aware that in other doula models that are not community-based, and probably in some community-based models, doulas are often taught that we do not interrupt or we do not interfere with the medical care. And we don't do that as community-based doulas, but we certainly in very gently and thoughtful ways, because the microaggressions in hospital facilities for mothers and for doulas is real and happens constantly. And this is for any birthing person, never mind Black and women of color. So we do prompt. We do bring to attention things for mom. We don't interrupt doctors, but if we know something is happening in front of us and the mother isn't aware, we will gently prompt like, hey, I see that you have a hook. Could you explain to mom, what you're going to do or what? Because sometimes residents will walk right in to the room and just, go for it. And you're like, wait, what's going on here? But one thing that to consider is that there are mothers out there that are birthing and have had prenatal care at like a federal qualified health center, where the provider that they're seeing, which could be up to 6 sometimes, isn't the person that's going to be at that delivery, and that federal qualified health center and that birthing hospital are not having conversations, because the amount of families that they are seeing, some midwives I know see up to 20 patients a day, sometimes more, sometimes less, because Medicaid is not paying what a private insurance company would pay. So the volume is higher because you have to make ends meet at the end of the day, right? And so mothers don't ability of having those conversations prenatally with their care provider, because the same care provider isn't the same person at their delivery. They might be at a teaching hospital where they have several residents, or quite a few residents who are changing shifts, and then you have an attending. So the reality for families and for doulas isn't consistent across the board for every birthing family. And at Sister to Sister, I don't like the taunt walking around. I come from an anti-racist framework, but I just come from seeing I hold the director, but my role is really as a facilitator and making sure people get paid and make sure the program continues to go. That's my role within this work.
Thank you so much for that. So we could spend, we're trying to be mindful of time. This conversation could be, a half-day symposium or a full-day symposium. So I will try to move us along a little quicker, but we do have some questions that are popping up in the chat. If we don't get to the questions in this conversation, we will try to get the information out. And this is a starter. This is not the beginning and the end in one conversation. As was noted at the beginning of our time, the graduates are representing 3 very different areas: Delaware, New York, and New Jersey. Our hope is that we're sparking, that this conversation is the spark, and that within our respective areas, we will then go on to do the advocacy, learn what legislation is, lingering and languishing in our state and federal houses of representatives, so that we can kind of push it. So again, we are going to try to get to them. We want to be mindful, but please do keep putting the questions into the chat. Also, one of my sorors will be popping questions in myth versus fact. So we're going to have that going on as well. Just to sort of pick up a thread that was present in all of your responses, stress. Right? It wasn't explicitly named as stress, but just all the things you need to think about, the communication that needs to happen, understanding the different roles, the different players. The pregnancy is a stressful event, right? It induces anxiety for many women, not all, but many. I'm in that number. I'll tell on myself. So let's talk about maternal stress a little bit. And here is one of our myths versus facts. Sorry, Hayes just had it up. So myth number 1, death from childbirth is a thing of the past. And as you can see from the slide, which I'm gonna minimize this so that I can see it. According to the CDC, 700 to 900 American women die each year as a result of pregnancy or childbirth complications. In fact, national maternal mortality rates have been increasing. remember at the start of this conversation, I said, we're in the United States, an industrialized advanced country, and yet this is what is happening. The US maternal mortality rate was 11.7 deaths per 100,000 live births. In 2016, the national maternal mortality rate was 19.9 deaths per 100,000 births. In some parts of the country, maternal deaths are even more common. For example, in Texas, the maternal mortality rate in 2014, which was the latest year statistics were available, was more than 30 deaths per 100,000 births. So again, this conversation is not meant to be a start and a stop, but truly a start and a spark. So I've spoken a little bit about maternal stress and what are some recommendations on ways to best cope with anxiety during each trimester, particularly in the living in the reality of a pandemic.
I think, oh, sorry.
Yeah, I was gonna actually start Tia, since you have with some virtual births.
Yeah, so part of that, you know, having a doula is definitely one way to help ease some of that anxiety, having someone to talk to that's knowledgeable about what that person is going through, and having, you know, the time and the, you know, the emotional capacity to help just grasp all of that with them, and the compassion of, you know, to hear how they're feeling and sympathize with them about what the stressors they're feeling, and just validating their feelings, you know, because during pregnancy, yes, stressors happen, and a lot of women and pregnant people don't like to talk about them because it's like, oh, someone's going to shame me, because it's like, well, you know, be thankful you're pregnant, or, you know, you should be thankful for this, that, and the third. And it's like, your feelings are still very real and valid. So just being able to speak with someone, having a support group is another one I would say. Having a support group, even if it's virtually, or if you're going to meet, you know, open somewhere, social distance, you know, in a parking lot or park or whatnot, but having a support group is helpful as well. Like maybe having say you're giving birth in June, maybe having a June mom group or June birth group or whatnot. And that way you can, you know, bounce off, you know, your feelings and stuff with other people who are birthing in the same month or around the same time. But having a doula, or, you know, just some type of support person who understands what you're going through and is there to help validate your feelings, to help to talk those feelings out. And if need be, may have references for a specialist if maybe that's something that you need, that person needs to go through a route, a therapist, or a psychologist, you know, somebody, you know, a doula can have those resources as well, and say, hey, you know, have you thought about speaking to someone? You know, why don't you talk to your OB or talk to your midwife about it? But I have references if you want any. Mm-hmm. But just having someone to just talk, you know, that space holding is a big thing that doulas do, is just holding space and letting, you know, parents just pour out whatever they need to, and not feel guilty about it, not feel bad. So yeah, again, having a doula, and also having a good support group where you can just all like, hey, y'all get me, like what's I just need to vent or talk or bounce questions. So yeah.
Well, just to kind of extend that, you know, we all may be familiar with Rumsfeld's dilemma, right? We know the things that we know the things that we don't know what we don't know. So for especially first-time moms, you know, someone who might be younger or who is coming from a lower socioeconomic class and may not have the resources, the connections, how do we get this information to them? You know, if someone doesn't know that they don't know this, how can we, you know, people who are on this call and others who are of the same mindset, really help connect people to those support groups and let them know that it's okay to have these conversations?
It's difficult, right? And we're in a setting where we have things like social media, and all of this access, but then none, right? Like we sit back and don't know where to go and how to find a lot of information. And then we have, the access of the internet, and we still see that there's a lot of misinformation out there, and a lot of ways that we're really just not connecting. So one of the things that we try to do, again, for me, is always starting with education, and making sure that I do childbirth education classes for local high schools. I go to the libraries, I go to churches, I go to, well, before, I used to be able to sit myself right and plop in the, in ShopRite or whatever, and be able to have people come over and talk about what should I be buying, during my pregnancy, talking about nutrition and things like that. So I think it's so important to be able to connect resources and have people to be open with sharing their resources and not be afraid to ask questions. And so, a place like yourselves, a sorority, should be able to house a list of local areas that are supplying, free childbirth education or free nutrition conversation, all of those setup of resources and things. But what I also want to make sure that everybody realizes that we're missing a huge part here. We're talking a whole lot about the pregnant person, and we're really not talking about the partner in this. Mm-hmm. And the partner can be one of the first and foremost persons who can provide all of that support and the listening ear and, all of those things. And it's one of the reasons why you mentioned in my bio that my husband teaches childbirth education classes with me, because that partner lens and that partner connection, oftentimes they're feeling left out, right? There's a childbirth education class. They don't know that they can go to that. They want to know too, what's happening. So really sort of pulling the partner in and pulling in grandparents. And I do a grandparent class as well. So I think that we have resources within ourselves. We're just not used to sharing that information, across the board with everybody. But I feel honestly, those are the biggest pieces. Like you said, you don't know what you don't know. And oftentimes, specifically when, and I think this is a hard thing to say, is when I have a pregnant person in one of my classes who has no idea where the baby's coming out. Mm-hmm, mm-hmm. Not really understanding what her body looks like, right? And what her pelvic floor looks like. So we need to do a lot of training and a lot of education, and we need to start with ourselves. And you don't need to be, somebody was asking, what can I do? What can I do? You don't need to be a certified doula. You don't need to be a midwife. You don't need to be a doctor. You don't need to be anything. And if you know body parts, then you need to start sharing that with people. Right. You really do need to start having these conversations and talking about, the taboo topics that have been, part of our community, part of our Black community for a very, very long time, is not talking about our bodies. So we really need to start with that first and foremost. When menstruation starts, and Lord knows I need somebody to talk to me about menopause. So those are all of these things that, that we just struggle with as a community. Right. Looking at our culture, some of those things are holding us back because we're not sharing those things with each other. Mm-hmm.
So true. I mean, I won't give away my age. I will say I'm starting to have the perimenopause conversation, if that gives you any clue. But I remember as a young girl, my mom and I didn't have these conversations. When I first started menstruating, first time I said, well, something happened. She gave me $5, said, all right, we'll go to the store. And, that was it. But on this line of really having the conversations, letting folks know that the resources are available, Rachel, I just wanted to come to you for a moment as someone who is folks who are in the community. And just as a reminder, if you are not speaking, please make sure that your mic is muted. As someone who's training folks who are working in the community, sadly and often overlooked segment has to do with folks who are housing insecure. Is that ever a part of the conversation, or the things to ask about, think about, be aware of?
Yeah, so at Sister to Sister within the community-based model, before we assign births, we take into account some of the social or economic stressors or things going on in someone's life that are outside of their pregnancy. And so we do that. And unfortunately, there's a shortage of housing in America. And gentrification going on, and that's happening in Newark, and it's happening in Essex County and all over New Jersey. So we often come and we do have challenges with families where a lot of families might be living with someone and sleeping on the couch, or all of these different scenarios, and there isn't a lot of resolve for housing insecurities. It's probably the most stressful and challenging situation to resolve in someone's life. You can't just, get someone's food stamps. You can't just go do that. Housing is a very different scenario. We have actually had people evicted in the postpartum period and not have anywhere to go except a shelter. And then you have dad can't go to a family shelter. So now the whole family's removed and living separately during a postpartum period. So housing is not something that is easily resolved, and I don't really have an answer for you regarding housing. I believe that New Jersey, I don't know how effective it will be because I want to acknowledge the effort that people make at the state level to try to remedy some situations, but I can't say it's done well, or that I think that it's always done with the community at heart. I think people try, but there is a new initiative going on that is trying to resolve housing challenges specifically for pregnant people. So that's a new initiative in New Jersey, and we'll see what happens. Yeah.
Thank you for that.
No worries.
We do have another myth that's up on the screen. Maternal mortality is only a problem in developing countries. Globally, almost all maternal deaths, 99% of them in fact, occur in developing countries, according to the World Health Organization. The average maternal mortality rate in developing countries in 2015 was 239 per 100,000 live births, compared to just 12 per 100,000 live births in developed countries. However, America exceeds the average rate, despite easy availability of clean water and, on paper, a sophisticated health system. According to a Save the Children report, the United States has the worst maternal mortality rate of any developed country in the world. A woman in the United States is more than 10 times as likely as a woman in Austria, Belarus, or Poland to die of a pregnancy-related cause. In 2017, the United States ranked 50th globally for its maternal mortality rate. Looking at this and reflecting on the last question about anxiety and stressors, here I want to introduce the postpartum period. So Michelle and Rachel, you both touched on it a little bit in your responses. If you all can just share, how long is the postpartum period? You know, when we think about maternal health, most folks think, okay, well, once the baby is born, then you're not in that maternal stage anymore, not understanding that there is a postpartum period. So if we could just hear, what is the time frame? You know, is it the 6 weeks until you go back for your follow-up visit, or does it extend for, you know, the first year of the child's life until they're no longer an infant? Tanya, were you looking to unmute yourself? Or did I just put that thought in your head?
She can answer. She's the OB, and I'll follow up.
So I was actually typing in the box. I just wanted to answer someone's question about what are the top causes of maternal death for African American women. And unfortunately, we're looking at hemorrhage and preeclampsia as two of the biggest leading causes of maternal mortality. The biggest concern, I think, around maternal mortality is that in the past, statistically, we were not capturing the real postpartum period, which really extends to at least up to a year after the baby's born. There are so many catastrophic events that take place because women are discharged home from the hospital. They're given some guidelines. They're told, here's some numbers, like call us if you have any questions. Maybe the postpartum visit itself is not valued by the care provider, and the patient is not aware of the significance or the importance of follow-up care. And if they don't have anyone visiting them at home, typically not through a traditional institution, unless that arrangements are made, or they're working with a home health provider or a doula that does follow-up, they might just be out there with a symptom that will lead them down a really bad path. People feel very alone in the postpartum period. And I'm sorry to say, knick-knack, I was partially listening to your question because I was typing an answer, so I'll pass the mic. But if the postpartum period is a significant place where we could make a big difference, specifically for women of color in the United States, women that have less resources, and trying to address maternal mortality.
Thank you. And Michelle, did you want to add something?
Yeah,
follow-up?
I'm
Yes.
here. So yes, you know, we really do need to change. Again, this is a cultural thing, right? We see this in the US more than we do in any other country. I work in Germany a lot, and a lot of my colleagues there have 3 to 5 years off, you know, postpartum to have their babies, and they come back, you know, and their jobs are secure. That's not the case here. There are some women who are very lucky if they get 6 weeks off afterwards. But the postpartum period, yes, should extend to the full year of the baby and of the mom. We also want to start to really at least kind of introduce the concept of what's called the 4th trimester, and build that more, you know, giving that extra 3 months after the baby is born for real kind of attuned care, really kind of focusing in on what's going on with mom, what's going on with the baby. But, you know, the baby will probably have, you know, 5 or 6 appointments with the pediatrician before the mother is seen once.
Right.
And so that's a horrible thing. I know the ACOG has come out with the option of seeing the mother 2 weeks instead of 6 weeks now. And, you know, we really have to make sure that there are OBs who are following that, or, you know, but again, it's seen as an option. So really kind of thinking about how often this person should be seen by someone, if not a medical professional, definitely somebody like a postpartum doula, or a community health worker, or someone who can come in and really kind of give overview and assessment as to how she's doing, maybe not medically, if they're not medical people, but at least emotionally and mentally, because we know postpartum depression is just a horrible, horrible, ugly monster that rears its head from right after the baby is born and can continue all the way up for 2 years or more. We see a lot of people who have postpartum depression, even beyond that quote time period that it's allowed for. So I really think that just if we can start, and I think it's a small start, to think about the 4th trimester and the care that a mother needs right after having this baby to heal her body, to reduce movement and the things that she feels that she needs to do right afterwards. That's why I'm such a huge advocate of putting together a postpartum plan, or and to me this is a plan, because this is who's going to be there for you to so you're not cooking and cleaning, so you're not doing laundry, so you're not carrying anything larger than your baby. Really kind of establishing that kind of protocol and making sure that that's set up, because you want all of the things, in the beginning of the birth in terms of how you want to birth, but how you heal is just as important, if not equally.
So thank you for that. I was just about to reflect back if I was hearing, what I was hearing was that the postpartum period should be a part of the birth preferences and not an afterthought, but included as you're beginning, you're having those conversations, whether it's you're sexually active or that line appears on that stick, including that as well. So thank you for that. Just to, I was teasing a little bit when I said, I'm in the range where I can start having that perimenopause conversation, which reminded me of a subset of women who often feel awkward or left out of conversations. And that is those women who, for whatever reason, are looking to have children at the age of 35 or beyond, right? And just if we can talk about that a little bit, is pregnancy over 35 truly a risk? And if so, what are the risks? A couple of years ago, I went to visit a gynecologist, and she said, oh yeah, well, everything's still working. You can have some more. I said, excuse me, what? Did I tell you how old my children are? Why do you think I'm going to have another one? But, I stopped and I thought, wow, could I? Because I am over the age of 35, is it truly a risk? And what do women over the age of 35 need to be concerned about? I don't know if our OB wants to take that one first.
Sure, I'd be happy to. So in general, there are some people that have a belief that the best suited people to give birth are like the teenagers, physiologically speaking. Sometimes when you see a teenage birth, the pain thresholds might be different, and sometimes the birth can be pretty uncomplicated because they're medically uncomplicated. So that's like a kind of a weird mythology around when were we made to have babies? Maybe when we're younger than we're doing it now in America in 2021. There are so many women that for various really critical, important, and autonomous reasons have decided to delay childbirth or decide later on that they would like to have children when they previously didn't want to. The one strange thing to remember is as time passes, we just accumulate risk. And that's the sort of medical lens on it. So when you're 17, the chance you have high blood pressure is pretty low. But when you're 20, it goes up a little bit. When you're 30, it goes up a little more. We start screening for diseases as they relate to age. And as you age, risk factors for disease accumulate. So by the time someone is 35, depending on their family history and other medical conditions, you've accumulated risk over time. Under no circumstance is having a baby at 35 or older in and of itself a dangerous thing. The question is, what is going on in that person's life at age 35 if they have, kind of spent their life feeling relatively healthy, avoided maybe screening exams, and suddenly discover when they find out that they're pregnant that they also have high blood pressure and gestational diabetes at age 35, because those risks do go up as you get older. In addition, once you get to age 35, there is a measurable difference in the risk of genetic anomalies in the developing fetus. All that to say, over time, our bodies accumulate risk, and that has a role in the experience of pregnancy, in the potential medical outcomes for the mom, the delivering person, and the baby. So the risks are present, but the truth is we make decisions through our entire lives based on various risk factors, and we make decisions knowing that there are risks involved because of our values and what's important to us. We take care of so many people at our hospital that are over age 35 and do wonderfully and have wonderful births and unmedicated birth and uncomplicated birth. The question is, just looking at all the factors, statistically speaking, over time, risk does accumulate. So the joke about teenagers and the ease of a lot of teenagers' deliveries really just comes down to the fact they haven't accumulated too much risk in their shorter lives.
Mm-hmm. Mm-hmm. Thank you. And did our doulas want to add any follow-up perspectives?
Sure, I can. I'm also an evidence-based birth instructor, and so I do a lot of trainings in nursing schools and med schools, really around these, these statistical numbers. And so I did my homework for this question. So the thing is that we're seeing, just as a cultural shift, a delay in having children for whatever reason, as Dr. Tanya mentioned personally. That right now, in terms of the numbers, is about 15% of all births are women who are over 35. The risk factors are definitely genetic, or definitely the possibility of miscarriage, and definitely the possibility of stillbirths. But again, it is an increased risk, but it really is looking at that risk from in comparison to absolute versus relative. Most times, the numbers are given in a very relative way, and you hear percentages, these really high percentages. But when you look at what the absolute risks are, I think that, to me, is what way more informed consent. Then you can look at the possibility and make that decision on your own to determine whether or not my risk at, let's say, for instance, for genetic risk factors is 1 out of 1,065 if I'm 25 years old, or now it's 1 out of 340 at 35. So you really are looking at those numbers in a very absolute way and making a determination as a family whether or not that's a risk you're willing to take. I know all of this also personally, because my second child was born when I was 39, at home, Christmas nights, amazingly, 6.5-hour birth. Rocked it. It was great. But again, my risks were lower because I'd already had a baby before too. So we shouldn't just look at the fact that you're 35 and over. It's how many children did you have before you were 35? Because that can actually lower your risk as well in those numbers. So again, starting off as to whether or not you're super happy and healthy, you have no conditions coming into your pregnancy, you're not at high risk for any of these things, just from a genetic factor. And for if you were really in touch with your OB or your midwife and really thinking about what makes sense for you, and really understanding the risks, getting all of the informed consent ahead of time. I think in general, it's not a bad idea, to be able to be pregnant, over 35. After having my baby at 39, my OB had a real deep conversation with me, and she was like, I kind of hope you're done, because, your eggs are going to get scrambled real soon. So those were like real kind of interesting things that she said to me. But in the end, I personally had made the decision that I was done, not listening to what she said. So I think taking those numbers into account, and I can share that with your group, the resources, the documentation, and everything with regard to advanced maternal age, and those numbers, so people can make real informed decisions.
Thank you for that. And I am being mindful of the time. I know that this is such a fulfilling, engaging conversation, and you all are sharing some real gems with us this evening. But we don't want to hold people too much longer. So I'm going to ask this, and this is for all of our panelists. A lot of this comes down to communication, to education, to conversation. How can we educate doctors, healthcare providers, the community on Black maternal health? And as you're sort of formulating the answer, I shared with the committee when we were planning for this event. For me, at first I was going to a hospital. I was on Medicaid, didn't have a lot of money, and didn't like how I was being treated. I didn't like the care I was getting at this hospital. The hospital no longer stands alone, is now part of the Health and Hospital Corporation. I won't name the hospital. But, they would schedule 20 to 30 of us at one time for our visit. So we'd all show up at 9 o'clock, and they would call us in batches of 10. Okay, you 10 go do your weight, you 10, go give your urine sample. And, when you spoke about seeing a doctor for all of 5 minutes, and it may not have been the doctor who was going to be with you during your birth, that was very real. And I was fortunate and blessed enough that I worked with a couple who had given birth to their, to a child, and had a lot of books and resources they didn't need anymore. And in going through those, that's when I learned about the birth center that I ended up connecting with. And thankfully, that center did accept Medicaid. So I didn't have to worry about how I was going to pay for it. But even in exploring and coming up with, changing my birth preference, trying to explain it to family and friends, they said, well, what do you mean? Are you giving birth in your bedroom? What are you doing? There just wasn't a real understanding of it, even in my own circle. And really, I had to find the strength and the conviction in what my choices were, to then be able to withstand the questions and the side eye that I was getting. So again, with that in mind, how do we go out and educate other folks as we are exploring different maternal plans and preferences?
Hi, this is Rachel. So I think that it's important that we see ourselves as consumers, because money moves. Even for the person that doesn't feel like they have a choice. Like if there are 2 hospitals in a city, you go to the one that moves you, and the one that speaks for you as best you can, right? And so I think as consumers, we need to direct our decisions as best as we are able in the decision that speaks for us, because it's not our job as a consumer or a pregnant person in that moment to educate and try to support our provider to get us, right? Like we want that, but like people are medically cultured in a way or have gone to school here, right? And not all doctors and not all midwives function the same or are the same. And so I think that it's really important that we start with our medical schools and our midwifery training programs in holding up what's high quality, respectful maternity care and a human rights based approach to maternity care. And that we make decisions as consumers based on, you know, exactly what our gut tells us, but also what is that hospital C-section rate, and make the decisions as best as we are able that align with us. And I really am a firm believer in system accountability and transparency, because that is where these numbers are going to change. That, like, we can support families to make good decisions and to eat well and to do all the things right, and it still might not end up in the safest, you know, the safest birth outcome. We really need to hold systems accountable and medical school and midwifery programs accountable to be the change. And whatever that means, as a consumer, like, go to your local legislator, go to your local, you know, community board at your hospital and speak out what you are hearing and ask for accountability as a local community member, and as a you know, you have the power to do it. So it's not always, I think that's where it changes. I don't think it's about asking a pregnant person to do it, but really it's and it has to be more than one person. Obviously, it has to be a collective of people. Yeah.
Thank you, Rachel. I don't know, Tanya, Michelle, T, I don't know who wanted to jump in there next, just about educating folks, you know, because again, sometimes it's our own folks we need to educate.
And you are so right when it comes to saying that. I think we have our own kind of issues or biases within, you know, within the way we approach physicians. You know, we may have given physicians a little bit of a God complex, and we kind of listen to whatever they say. I mean, you hear your grandma, you do exactly what the doctor says, right? So there's just always that kind of place where we're kind of raised not to question, right? Not to really kind of exert what we're feeling exactly. And I think, you know, it starts with us. You know, everybody hearing this now, you know, it's the ripple effect. You know, go back and say, listen, you know, we spend, I always use this analogy in every single one of my classes. How much time do you spend researching your brand new car? How much time do you look at the reviews for the brand new television that you're about to buy?
Right.
Right. But when it comes to your healthcare, when it comes to your physician, then in a place that you can, right? Clearly, this is not going to work for everybody, but in a place where you can, from a consumer point of view, what's the Yelp review for that doctor? Right? Or that hospital. Like, you know, Rachel was talking about, what's the C-section rate of the hospital you're about to birth in? What's the episiotomy rate? Understanding that you're going to walk into problems that you may not even want because of the way that they're practicing, their lens, their culture that's in the hospital space. So definitely going in and starting fresh. And that's where I really kind of feel like we're going to change or be change makers. And this is why I teach classes in nursing schools. This is why I go to, you know, I do the resident rounds at my local hospitals, and I give, you know, classes there. So it is definitely making sure that everybody has all the information, all of the evidence, and whomever is listening is who I'm reaching. Whoever wants to make sure that their instruments of change are inviting me in.
Sorry, my dog was aggressively answering someone outside, so I had to mute myself. So just keep talking. I'm gonna mute myself though.
I'm surprised my dog didn't chime in and answer back to your dog. But I definitely agree with Michelle's point, especially with a lot of African-American upbringing of do as you're told and not to question. That carries over for a lot of people into what their teacher tells them, what their doctors tell them. They don't question it because that is looked at as an authority. And it's like, how dare you question authority when, you know, that was your upbringing, your grandma, like, don't talk back, don't, you do as you told, you know, like, so that, and I've like experienced that sometimes too of, oh, you know, I guess I should do what, you know, what the doctor said because the doctor, like, they know what they're talking about, right? You know your body. Like, you have to encourage, you know, pregnant people, they know their body too. They're feeling everything. So being able to articulate what they're feeling. But yeah, that being, you know, somewhat afraid to challenge what a doctor says, what a nurse says, or suggests or recommends. And it's like, I encourage people, challenge is not a negative thing. Like it's not controversial. It's okay to challenge and ask questions like, oh, why are you suggesting this now? Is this necessary? You know, do we have to do this now? Is there an alternative? So like for the doulas who might know the BRAIN acronym, we're going through like the benefits and risks and alternatives and intuition and stuff. So it's like asking questions. It's okay to ask questions, but for a lot of African Americans, a lot of that upbringing is don't ask questions, just do as you're told. Right. So it's like now growing up, becoming an adult and making decisions for yourself, it is tough to try to break out of that mentality and know that it's okay now to ask questions, and you should. But when it comes to like your provider and helping to educate them, or not even just to educate them, like if you have a doctor or new doctor or whatnot, ask them, you know, hey, do you know about the Black maternal mortality rate in the US? Like, what are you doing personally to combat that? Because right now I'm under your care. So I want to know that I'm safe under your care. And it's okay to ask about that. Hey, do you know about this? Do you feel like it's a problem? And if a doctor's like, no, red flag, exit stage left, we can go somewhere else. Because then you might already feel like you're going to have to fight for safety and pray that you and your baby come out of your pregnancy and delivery alive, if someone else doesn't already see that there is a racial struggle coming from a Black person in the medical system. So it's okay to go in there and ask those questions like, hey, what are your thoughts on the Black maternal mortality rate and what are you doing to combat that? And then, you know, starting from there doesn't mean you have to educate them. It's just like posing a question like, hey, I know I'm Black and I know I'm seeing you. So do you know what I'm dealing with as a Black person? And posing that question, and it doesn't mean that you're educating them, but it just puts in their mind that, hey, oh, they're aware and they know, and they're going to make sure that I know what's going on, that I'm doing something about it. So just posing a question and challenging things that, you know, you're told, it's like, hey, well, you need to take this, that, and the third. And it's like, oh, okay, well, you know, I read about X, Y, Z. What are your thoughts on that? And it doesn't mean that you're demeaning what they're saying. It's like, hey, you know, I came across something different. Does this apply to my health, or do I have to just stick with what you said, alternative to what you said? And just knowing that we can have that conversation, but finding a provider that understands and understands the Black struggle when it comes to maternal mortality and when it comes to just in the medical system, especially as pregnant people, making sure you have a provider that understands those feelings and those fears and those concerns. So when picking a provider, like my last birth was a home birth, and I previously had been seen by midwives in a hospital setting. Those midwives were the ones who saw me in a birth center setting, but it closed. So being pregnant in a pandemic, they moved, you know, birth center closed, they transitioned to the hospital. I was like, I'm not going from a birth center to a hospital, bro. I'm just not. Like, if I could put y'all in my pocket and take you home, I would. But having to find now, you know, being a creature of habit, I wanted to stick with them, but I did not want to stick with where I was going to see them, because being in a hospital setting, I didn't know, I knew them, but I didn't know what nurse was going to come in the room. I didn't know what kind of day she was going to have coming in the room. Would I have to start to, you know, fight for what I want, or, you know, knowing that I was low risk, would I have to, you know, say, you just checked my blood pressure 10 minutes ago, it's fine. You know, I don't want to have to have things interrupted in a low risk, low intervention birth experience that I could have had at home. But the midwife that I did choose, she was a white midwife. And there was one person that I was like, I want to make sure when I'm searching for an attendant, I want to make sure they understand right now, me being pregnant in a pandemic and racial, you know, all the George Floyds and the just all types of things happening right now in a pandemic, and me being Black and pregnant. I need you to understand, you know, what I'm feeling. And so picking a person who already was doing their own work internally and externally to understand, hey, these are the clientele that I am supporting as a midwife. You know, I want to make sure that you know that I'm here for you, and that I'm going to make sure you and your baby are safe.
Right.
So researching, you know, the person that's going to be there, the medical attendant that's going to be there to support you is very key. Like Michelle said, like, you're going to research everybody else. You need to research your doctor, research your midwife, research your doula.
Mm-hmm.
If you're hiring a doula and it's not, you know, a family friend or, you know, someone close to you, research that person too, because they're going to be there in a very vulnerable moment, in a very open space. When you're just open, like labor and birth just makes you wide open, like feelings, everything just comes out. So it's like having someone there that, you know, is going to keep that space safe. So research that. Who do you want there in your safe space?
Thank you for that. And Tanya, did you want to add anything to that question, just in the interfacing with, having dialogue with providers and the community?
Sure. I can say that I can relate to a lot of the comments that I heard about upbringing and being taught which authorities you're just supposed to take on face value. My family's from a small island underneath India, Sri Lanka, and my whole upbringing was, oh, people in authority, you got to listen to them. Also, being immigrants in this country, keeping a low profile was really important. Not stirring the water was really important. Saying yes to authority was pretty important. I see a lot of patients in my hospital that are new immigrants that don't have a lot of resources. They don't ask questions. When they do, I say, thank you. If you didn't ask me a question about what we're doing, it makes me worried. There's no way you understood everything I just explained.
Right.
It makes me know that we're together. You're not going to just say yes and then not know what just happened. I would say we are all aware of the history of racism in the United States, which has permeated every institution in the United States, which includes hospitals, which includes doctor culture, which includes medical culture, which includes the culture in teaching hospitals. We just had a conversation today about how many people should be in a labor room at the time of a woman's delivery at a teaching hospital. I want families to know that when they're interviewing perhaps an OB or a midwife practice, they should ask the question, how many people will be in the room at the time of my uncomplicated delivery? I'm not talking about the stat C-section, baby's heart rate, something very profoundly abnormal. I'm talking about, what is my expectation for calm, respectful, serene birth, if that is what is coming my way? You ask that question, you find out how much respect that community has for you as a birthing person. You ask the institution, what work have you done to understand racism at your institution? What trainings have you undergone? I'm not saying these are the solutions to everything. It just means that the place you're going to visit has at least tried to scratch the surface of the problems that we live in and the problems that we manifest and those people are trying to discover and elevate the truth about what healthcare is for different people in this country. If they don't know what you're talking about, or they say, but you know, doctors are not racist, which I just had to hear the other day, which is the most, how are doctors exempt from the culture of America? I'm not sure. That's a mystery to me. Ask those questions. What have you done? Look around, look what's happening in America. Look what's been happening for hundreds of years that we are all faced with, no matter what the color of your skin is. What is your institution doing to explore that? And your responsibility. Look for humility and respect. If you feel respected and you get a sense of humility from the person you'll be working with, and you feel a sense of trust, trust yourself, trust your gut. You're probably going to be in a good situation.
Wow.
Thank you so much for that. I just wanted to add, because I see something in the chat about values being important. And I know that there's a lot of hashtag representation matters and things like that. And to Dr. Tanya's point, not, and I guess what's the phrase? Not all skin folk or kinfolk.
Kinfolk, yep.
Right? Because I've been in spaces where there have been Black doctors, Black nurses who have done the worst to Black women. So that's why, for me, it's so important that people do the research and ask those types of questions that she was talking about, and don't just automatically assume that this person looks like me, that they're going to treat me well. That's not always the case. And that's basically what I wanted to just share, but thank you very much.
Well, thank you. And again, you all are so dynamic, and the work that you are doing is invaluable. So thank you for taking time out. I saw that Sora Diggs was kissing babies goodnight over there. And, you know, just the fact that you all recognize the importance and are so committed that you are willing to take time out of your schedules to not only plan and prepare, but also participate in this crucial discussion. So we thank you immensely for that. This conversation, this discussion is being recorded. I've been saving the chat, and we're gonna, you know, talk as a committee across the 3 graduate chapters about how can we get this information out even more, what the sort of next steps are. But I just want to draw your attention to the slide that's up on the screen. You know, as a social action committee or as a social action initiative, it's really about the tangible next steps, right? So the conversation is key, it is important, and it's the starting point. So really looking at what legislation is being discussed and considered. Right now, you know, and I'm have to say shameless plug, Robin Kelly, who is a member of Sigma Gamma Rho Sorority Incorporated and is a member of the House of Representatives, has brought forward the bill, the Mothers and Offspring Mortality and Morbidity Awareness, or MAMA Act. And this has been referred to the Health Committee. You can see on the screen a synopsis of what it does: extending Medicaid and the Children's Health Insurance Program, or CHIP, coverage to 1 year postpartum. So we spoke about that in tonight's discussion. For women who have pregnancy-related Medicaid or CHIP coverage, authorizes funding, standardizes maternal mortality and morbidity data collection, empowers the CDC to provide technical guidance and publish best practices, and authorizes funding for the Alliance for Innovation on Maternal Health Grant Program. So this is something that is, again, being considered at the federal level, that we can all educate ourselves about, educate community members on, and really get to your legislators and let them know that this is important and that action needs to be taken on it. We don't want it to just languish in committee. We also have the Black Maternal Health Caucus Momnibus, this also has been referred to health committees. And you can see the sponsors there, Representative Underwood, Representative Adams, and Senator Harris, or Vice President Harris. And the gist of that is composed of 9 individual bills sponsored by the Black Maternal Health Caucus members. And we can see all of the bullet points in terms of the aim, focus of this legislation. But again, we need to make sure that our voices are being heard, that we're mobilizing community members. You know, Sigma Gamma Rho Sorority Incorporated is a nonpartisan organization, so I would never, you know, say because this is being brought forth by one party over another. However, in our conversation this evening, we have spoken about, learned of the considerations, the subject matter, all the things that go into protecting pregnant people. And you protect pregnant people, you protect babies, and you protect communities. So please educate yourself on this. New Jersey, we have Senator Booker, who has brought forth the Maximizing Outcomes for Moms Through Medicaid Improvement and Enhancement of Services Act, or the Mommies Act. This has been introduced. So right now, I don't believe any action has been taken on this, as opposed to the previous 2 bills that have at least been referred to a committee. Overall, this would extend Medicaid coverage to 1 year postpartum, provide comprehensive benefits to women with pregnancy-related Medicaid coverage, establish a maternity care home demonstration project, increase Medicaid payments, require guidance and reports to increase access to doula services, and requires the U.S. Government Accountability Office to report on maternal health care in the United States, and on the use of telemedicine to increase access to maternity care. And with this, I would say, even with the telemedicine part, that also speaks to access to internet, right? So one of the things that we really learned, or which was really highlighted during the pandemic, was the fact that not everyone has, you know, Spectrum or whatever these other internet service providers are. So just you know, the connecting dot there. We're advocating for this. We're also advocating for broad access to internet services. And I don't, do we have another?
Nicole, can I just say that I wanted you to know that today, Senator Cory Booker was bringing this bill to caucus.
Awesome. Thank you so much for that update. Here we have the legislative context. Again, you have 3 chapters covering 3 different states: Delaware, New Jersey, New York. We have legislative context. So for those of you who are wondering, what can I do? What do I need to do? This is a tangible action step. Please make sure that you are reaching out to your representatives, that you're galvanizing your friends, your family, your contacts. Get behind these bills. This is going to be key to protecting the lives of pregnant people and their babies. Write letters, call. This is something where, you know, you can have a virtual kind of get together. Instead of a Tupperware party, we're gonna have an action plan party, right? I don't know if people still sell Mary Kay or not. Instead of anything else, we're gonna get together and we're gonna plan for this. And for those of us who are on this call who are members of Sigma Gamma Rho Sorority Incorporated, I have 2 words: golden service. I'm gonna give you 3 words: golden service hours. All right, we're on the road to Centennial, golden service hours. So we can absolutely plan community service around this very accessible action step in how to get involved. And did we have another slide? Oh, and look at how easy we made it for you. We got a sample script going on. My name is, I'm a constituent from, I'm calling to urge, please vote in support of and why we need their support. Will you, Senator so-and-so, be voting in support of this act? That's going to all representatives, regardless of their party affiliation. We want a deluge of letters and calls going to their offices. And of course, we're going to thank you for your time. You know how they do in the South? Bless your heart. Now go do this. So for more information, we have some websites up for you, marchformoms.org and cdc.gov. Hear her. You can absolutely get to it. But again, we have the recording. I promise you I've been saving the chat, and we are going to really think of how to thoughtfully and impactfully get this out, not only to those of you who joined us this evening, but communities at large. With that, I have to say thank you all to our panelists, to our everyone who tuned in. I hope that you feel as empowered and inspired as the committee members did as we were thinking of this and planning for this evening. And, you know, I'm just going to speak on our behalf and say that this time has exceeded our expectations. It was just incredible. And, you know, as we're preparing to wish each other good night and a peaceful weekend, if you would like to come off mute and just say thank you, or, you know, just say, hey, then please do that. This space was for you as well. But thank you, Rachel. Thank you, Tia.
Thank you.
Michelle. Tanya had to dial off a few moments ago, but truly, thank you so much.
Thank you, everyone. Awesome
Thank you,
programming.
thank you. Good night, everyone.
Thank you, thank you.
Hi, thank you for a good program. You guys were amazing.
Thank you
Thank
so
you
much
for
for your
having me.
support.
Thank you, guys.
Thank
you, Source. Thank you for the invitation.
Thank you so much. It was very informative. I learned so much.
Thank you, thank you. And spread the word.
All our speakers, you guys were phenomenal.
Yes.
I've learned so much tonight. And I just really want to thank everyone for coming out.
Amazing. Yes. Clap, high five, and all the other accolades.
They deserve them all.
Yes, yes, you all do, and especially the sorority as well for the great work of putting this together.
Thank you.
Thank you so much.
God bless you all. Good night.
Good night.
Good night. Be well.
Good night.
Letters and
Everyone.
phone calls.